Hello, everybody. Welcome again. Several of you are returning participants in person and online, but if you're not, I'm going to do a quick introduction about the symposium and the U21 Health Research Exchange. So you become familiar with it, and then we're going to walk into and move into our talk with our speaker from University of Birmingham, and I'll introduce him as well. But first of all, again, welcome. This is the last session of the two-day symposium. We're very excited. This is a special topics session on health equity in the UK healthcare system. But before we go over that, just again, a background again about the Health Research Exchange. The Universitas 21 Health Research Exchange was created in 2020 in response to the COVID pandemic, where we wanted to create opportunity for collaboration and engagement for doctoral students and early career researchers, particularly underrepresented groups in the healthcare field for health policy management and services. But it really is an interdisciplinary and overall public health focused platform where students and researchers from across various nations that are part of the U21, which is short for Universitas 21, where they can collaborate, engage with each other with member institutions. Universitas 21 or U21 is a global network. It's actually housed in Birmingham, University of Birmingham, I believe. We are, as College Park campus, we are one of only three US universities that are part of this global network. Now it has moved up to 29 member universities around the world, as opposed to 21 when they started. But again, we started that at that point to make sure that we create opportunity for students and early career researchers. As part of this third symposium talk now, I'm going to ask Professor Mark Exworthy to come up and sit on this table over here so I can introduce you. So Professor Mark Exworthy is from University of Birmingham. He's a colleague and a good friend of mine, and we actually created with a larger team of our students and early career researchers, we created the U21 Health Research Exchange, and I'm going to call it HREx for short, in 2020. So it was me and him and a whole bunch of other folks from UMD, our students, and Birmingham. And then the second iteration in 21, it brought in University College Dublin with my colleagues sitting in the front row here, and University of New South Wales, who couldn't join us today. But it truly has been an international collaborative effort to create a virtual platform. This is the very first time we're meeting in person and the last one of the symposium. But I just want to say in this part that look forward to something else coming up. We didn't mention this earlier, but in September, in the fall semester, we are actually going to go up to University of Birmingham from Maryland with a Maryland team. And hopefully our UCD colleagues will join us, and we will most likely have something similar, another symposium. Maybe we can call it the fall symposium. And this was the spring symposium, we don't know, but in the fall. So look forward to emails and event information for that in the future. Okay, so as part of this third talk, Professor Exworthy is going to talk about health equity issues in the UK. And I'm just going to fast forward to the next slides for him. And I forgot to add this in here, show you all this. This is the set of team members that actually we have been involved in creating this platform over the past 3 years. And two slides with the inclusive team members, most of them that are actually here today. All right, here you go, Professor Exworthy.
Good.
Take it away.
Thank you. Well, as Nagin said, it's just amazing to be here. So many Zoom calls, and then suddenly, oh, we're actually in place. So I still get a bit of a shiver thinking that COVID happened and it was Zoom just only, and now we're actually meeting in person. So yeah, really pleased to be here. Thank you for the warm welcome. Really, thank you for all your support, and people at the back, people at the various the front, at various levels to get this meeting underway. So now I've got to talk, but I'd quite like to keep it a bit open if there are any issues that we raise or I raise that you would like. Just please do stop. Raise questions. I'm not going to be talking all the time. I have got one deliberate thing I want you to get involved in. and that will become clear, I guess, as we go through. So the topic, Negin said, well, could you, when you're here, could you do a talk? And I thought, okay, let's think of what would be of interest. And the story of this health equity is fascinating, because it seems to be fairly front and center in a lot of what the US and I guess to some extent the Irish system as well is now looking at. But this journey for me started 20 years ago when I had a fellowship on the other side of this country in California looking at health equity. So a little bit of this talk is sort of coming full circle. So I'm really interested to know, and I've got my notepad there to go to take notes about how the US is tackling this issue now, 2023. I'll be able to compare it with my work those years ago. A, to see whether we've learned anything, to see how we can build better, more equitable health systems, and have that discussion. So I'm definitely going to learn something from this, and that's from you. But hopefully I will prompt a few ideas and prompt a few. Oh, thank you. Yeah, I'm not going to learn just right this minute, but yeah, thank you. Thank you. So the way I'm going to structure this is in two parts. The first part is a little bit about getting our definitions right. And then the second part is looking at what the UK has been doing, because apparently we have some health inequalities that we, yeah. And then I want to give you kind of a bit of a theoretical conceptual lens to see how you can help understand and explain why progress might be the way it is. Because 20 years ago, I think the US was starting on this journey, and I think you still have a few inequalities and a few disparities. So I might use those terms interchangeably. I probably focus on the equity inequality dimension. We can get into a bit of a discussion. So those of you who have visited London, London's not the only city in the UK. We, from Birmingham is different, but we don't have this. So there is the metro system's called the Tube, and on the Tube they have these signs by the as you step onto the train called "Mind the Gap," and in a way that's what I want you to remember to mind the gap here, the health gaps that we're going to be talking about. Just interestingly, we had a new king recently, and just the day or so before they recorded an announcement for the tube system, which was please mind the gap. So you had the king saying mind the gap. I should have had that on I should have had that on the audio, and that would have been great. He wasn't talking about health equity, by the way. He was just talking about the step for the tube trains. But anyway, I think it's just a kind of a silly start to the talk. Anyway, let's get kind of into a bit of kind of the definition part, and then I want to open it up to your view. So Barbara Starfield was quite an amazing scholar. She was based at Johns Hopkins, not too far away, and she's quite well remembered for her work on primary care. Well worth looking at still. But she was also a advocate and writer on health equity issues. So some of the aspects of this definition, I just think kind of cover pretty much a lot of what we're looking at. So systematic, this is, in other words, it's right through the whole system. So in other words, the complexity of health inequalities means that there are various different entry points. In other words, it's not just one door into this. It's remediable. So these are not given, fixed. We can't do anything about them. Let's go home. In aspects of health across populations or population groups, socially, economically, demographically, or geographically. It's a fairly comprehensive definition that is perhaps kind of in some senses overwhelming, because it covers so many different aspects. We can argue about how the wording of it, but kind of graphically, I find this image quite a good one. There are some other ones that I think you probably have seen, which are related to justice as well. as well. For simplicity, I've just put the kind of two aspects on it. So on the left, you have the equality. So in other words, all the folks trying to note, I put the kind of the US reference here to the baseball game. You know, it would be cricket, obviously, or maybe Manchester United. I don't know if given Amanpreet's club, trying to look into the game. So you could say, well, kind of there's an access issue there. There's a barrier, which is the fence, and the help is given a step up. But of course, people are different. People start. So it's in relation to their needs. So an equal approach is a starting point, but it doesn't recognize the differences between individuals. Equity builds that in. It recognizes that people are different and people will need different aspects. So from a philosophical point of view, it's about unequal measures for unequal people. Sorry, that's a very brief summary, but it's trying to recognize. So I suppose kind of so far so good, but there is a dimension when we start to bring it into healthcare, particularly, and my interest is how then policymakers take up this issue. How do they themselves define this issue? And some work I've done with Martin Powell looks at the two questions, the who and the what question. So if it's equity, the right-hand image of the people trying to look into the baseball game, for whom is it equitable and what is equitable? So probably the left-hand side, you'd be fairly, you guys could do this, you know, it's demographic groups, it's racial and ethnic groups, it's geographical groups, etc., etc. So the who is, yeah, it's people, but which people? The second box, the right-hand box, I think is a little more, a bit more tricky, and partly because it relates to the healthcare issue, I suppose. So a very simple way would be kind of inputs, outputs, outcomes, the kind of Donabedian sort of structure. We might also add access in there. These are not exclusive lists. You might add some other aspects into it. But you can start to see how a policy prescription, a policy program, an initiative might start to blend different aspects of the left-hand box and the right-hand box in that strategy. So, for example, it may be a particular geographical community and how they get access to services. So if you draw that as a nice grid, a matrix, just in this diagram, you've got what, a 4 by 4 grid. So you've got a number of different cells of that 2 by 2 matrix. Any initiative will struggle to fill all 16 cells. You won't be able to do it, partly because, you know, the nature of the funding or the nature of your program or whatever. So, but recognizing that you are going to be having to make choices, deliberate choices, hopefully, through engagement, through consultation, etc. It inevitably involves a compromise, a trade-off that you're going to not be able to tackle some other aspects. The right-hand side is interesting because the level of difficulty increases as we go down that list on the right-hand side. Perhaps we can argue whether it does on the left-hand side, maybe not, I don't know. I think it's slightly different. But on the right-hand side, in some ways, I think we are dealing with a progressively more difficult, complex issue. So in some sense, we can say that the inputs are trying to get some equity of inputs. Equity of staffing. So some of the distribution of staffing. There have been programs certainly in the UK and in the US, medical underserved areas, restricting the distribution of staff to work in those areas might be one of those. I'm not saying that's easy, but trying to get equity of outcomes is that much harder. We, generally speaking, health systems have tended to be equity of access or equity of inputs. As you go down that list, if we use the social determinants of health model, the rainbow model that's used by Dahlgren and Whitehead, you are looking at moving further and further away from that initial core into areas that are the social determinants of housing, of education, the factors that we know will affect health. Healthcare, McGuinness and colleagues 20 years ago said it's about 15% of health improvement will be healthcare. So if you're going to try and move into those other, further down that list on the right-hand side, equity of what, you're going to be having to address many more dimensions way beyond healthcare. Now, you guys know that. That's probably kind of 101, but it's how the policymakers then have to engage. And surprise, not really. They tend to go for the kind of slightly easier definitions of equity, access maybe, or inputs. Not to say that's kind of a given. We can, those are still highly complex, but we are way short of getting anything like equity of outcome, which could be a legitimate policy goal. We could say that would be for our system. We would like, ideally, in an ideal world, we would like to achieve that, but surprise, it's not so. So let's just get on to a couple of other examples. So we're talking about equity here, but equity, well, how does this demonstrate it? And I'll just give you a couple of examples from the UK. So this is taking the deciles across deprivation, kind of a proxy kind of for socioeconomic measures. For males and females, they're the two green shades of the boxes, and this is life expectancy at birth. And you can see that the most deprived on the left has life expectancies. I don't know if you can read it at the back on the left. The lowest or the base of the vertical axis is 70 years, and it goes up to 90. So you're looking at gaps which has been put on the right hand side. Female of 7 years, 7.7, and 9.5 for men. So the gap between the poorest 10% and the most affluent is in a factor of 9.5 and 7.7 years. Okay, so that's pretty terrible. This is data. Well, it was published a couple of years ago, but my point here is not, as you can probably tell, I'm not an epidemiologist focusing on the data. There won't be too many slides like this. It's about why is that graph still that gradient, that slope? So we might say, yes, okay, the poorest are going to be have, in this case, shorter life expectancy than the wealth. But why would it be that sort of educational attainment, access to healthcare, you choose the measure, would show a similar gradient? I'm not going to say a gradient slope. We're not going to get into a percentage, but there is a progressive increase in life expectancy, to use this example. So why would that be? Why is it that somebody who is in the middle of this, in the 5th decile, probably reasonable job, reasonable pay, in the UK would have access to healthcare, have a pretty good life? Why is their life expectancy, I'm just going to try and do some quick maths, maybe 2, 3, 4 years less than somebody who's a wealthier, in a few deciles higher, shorter than them, but more than the other groups? Why is it we would see that sort of that slope? So that's my first kind of question to you. Why have we got that? If you just shout out, I'll
wait a second, bring the microphone.
Because that's kind of a policy conundrum, because it's and I'll come to explain why that might be.
What do you all think? Take a gander. Yeah, Portia?
So this is area level.
Hold on.
Yes. Okay. So this is kind of neighborhood level type. Yeah.
So,
Yeah.
I mean,
true.
yeah. So one reasoning, of course, is we know that there is
differences in the type of resources, right?
Yeah.
In terms of where folks live, right? So that's one reason, right? So then you live in an under-resourced area, and this is perpetual cycle of not getting resources that are needed to, for instance, access proper healthcare,
Yeah.
or even manage your health outside the healthcare system, right? So just your just daily living, you may have issues with food insecurity, traveling, maybe you're taking public transportation, you don't own a car. So there's all these contextual disadvantages in terms of the resources that you're able to access because of where you live, right? So that's probably one thing that's constant, that is continuously driving this gap
True.
here.
But why would that be even in the 5th decile, 6th decile? Those would be folks that would have pretty good access to, I'm not saying it would not be there, but they'd have pretty good food security, pretty good access to healthcare. They'd probably have a job that would be paying a reasonable amount. In the UK, that would be school teachers, for example, nurses, maybe, that sort of level. It's just got to get onto what that would mean in specific jobs. Yeah.
Introduce yourself.
Yeah, I'm an alumnus of UMD School of Public Health. I did her program, yes. So one thing that I thought of, and it might be a little bit off tangent of what you were trying to get at, was when we look at life expectancy and particularly for populations. Social system as you get older, like for tired,
yeah,
they may be more reliant on public transportation, more reliant on family members, they more rely on neighborhood to maintain their health, things like that. And so that's where you sort of are getting between small differences add up to
right. Good. Yeah.
You had
Yeah.
Jenny back here.
I feel like I just wondered if there was a tipping point where people are able to start accessing private healthcare and private dental healthcare.
Maybe. I mean, maybe. Well, I think actually, not surprisingly, I think you're all right in a degree. Linking back to my definitions and the,
We have
one
one
more. Sorry.
Lori Simon Rasinowitz. I'm a faculty member here and as well as
In
in Megan's program, yes. And I am curious about redlining. Is that a term that is used in England?
No, but I know what you mean. Yeah.
Because that makes a big difference here.
Okay. Yeah. Okay. Yeah. So in a way, going back to the definitions that I had, the equity of the who and the what, we're looking at life expectancy. Okay. So this is an outcome that we would, so it's at the end of a very long process of life. So, and also, as you pointed out, this is a geographical neighborhood effect. So, this is the who is the geographical and the what is the outcome. So this is kind of a long way down the line, but still we have that conundrum of what it means in the middle. And Michael Marmot, who's I guess a lot of people will know, we'll talk about the gradient as the important dimension here, because and it relates quite often to what he'd call the status syndrome. It would be people are trying to improve themselves, but still have some sort of stress levels that would mean that you might be doing okay, but you're still going to have that expressed out through, in this case, life expectancy. And another example, slightly different slope of the line here, but this is just age standardized mortality, but particularly in relation to deaths involving COVID. The horizontal scale is flipped around here. So the right-hand side is the most deprived, and you can see death rates from COVID are much, much higher on the right-hand side, most deprived, than the left-hand side. And the 10th doesn't even register. So and you can see how the two boxes, the grey and the blue, are exacerbated by COVID. So the gradient, the grey gradient, yeah, the grey gradient is still showing that stepwise progression. But during COVID, it's just magnified up. So, it's an expression about the kind of inequalities going. To be fair, this is just the period of just what, 6 weeks at the very beginning of COVID. But my point is there's a similar gradient, and the question is how do we tackle that? Oh, wrong way. So so my next challenge, I've just tried to give you some examples of how we can define an approach. There's a book that was probably very impressionable on me when I was reading it. It's by Deborah Stone. It's called The Policy Paradox. And she has a great way of considering it. She talks about the cake, but it's about how we divide the cake. And she has a number of different ways of dividing the cake. So the question I'm going to put to you is how to divide the cake. I'm just going to give you a few examples. So we could cut each slice of that cake equally, and everybody will get an equal share of the cake. Okay, however many degrees of your slices. We might decide that those who baked the cake would deserve a slightly bigger slice. Those people who paid for the cake would deserve a slightly bigger slice. She then applies it to a university department, which I think is probably a bit, because she said the professors should get, she uses the word frosting, icing for a UK audience. Those professors should get the slice with the extra icing, frosting. Unfortunately, any undergraduates in the room, she said, well, they should have just the crumbs. So this is a thought experiment. Don't worry, this doesn't happen in real life. But there's a number of different ways that we could. Hopefully, you can do the calculation of cake healthcare. How should we divide the cake? How should we divide the cake? So, any thoughts on how we should slice up our healthcare? Ideally, you would put it kind of in an equitable lens rather than just having an equal share of that. But how could we apply that to healthcare? I don't know, probably you're starting to feel a bit, oh, I should have had a piece of cake at lunch.
Anybody?
How?
Well, so part of equity is understanding people have differences.
Yeah.
And so the first step is probably to identify what those differences or what those
Mhm.
needs are. So if we're making a cake reference,
Yeah.
this is a cake. Or diabetic.
Right.
Want any icing.
Yeah. Mhm.
Really,
Yes.
bottom of the cake. Or sugar, we see this as one big cake, one big valuable entity, but people are looking at it from very different angles.
Right.
And what you consider the most valuable
Mhm.
value system. Thing like
But
that.
I'm glad you used the word need there, because in a way it would be to translate to a cake kind of reference. It would be
Yeah.
the hunger.
Yeah.
Who's the most hungry for this cake? And the claims on that cake from people who paid for it or people who made the cake would be relegated in some way
Mhm.
in favor of need. So you're right.
Yeah, because-
that is the dominant way in which health systems would do it.
Yeah, and
Yeah.
I think it also goes back to the intention of, the purpose that this cake was made,
Right. Yes.
and
Yeah.
they must created the system or who are offering these services have on it. It's ultimately for the people to consume and use. I mean, that's the purpose of the health system.
And of course, that is some redistribution, because the people who made it or bought the cake or paid for the cake will be different from those who need to eat the cake. Correct. Yeah, exactly. Yeah.
Second.
Hi, yeah, right, I'm a student in the
The Fuladi School of
Yeah.
Public Health.
Just
Yes,
one thing I thought about is a lot of things about the scarcity. Cake.
exactly.
It's all we're gonna
Yeah,
have,
yeah.
but we need to make this cakes. We need to feed people. So
Yeah.
we can bake the next cake.
Let's have a bigger cake. Yeah, yeah.
and Let's bake more cake. Let's bake
Right.
more nutritious cake.
Yeah.
So sometimes we think of these not finite resources, but I think about what we do in the future, how we create resources, and certainly like supporting the health of populations frees up resources, it creates resources to have more cake.
I like that analogy because in a way it's the cake that I'm got in my mind has already been baked. But actually you're talking about, well, what about the next cake? And so there's a continual policy decisions that have to be made about how we allocate those resources, the slices of the cake.
Tempted to take a Rawlsian position on it. So not knowing who made the cake and not
Yes.
knowing
Yeah.
who the undergraduates were or who the professors were.
Yeah.
And then try and work from that sort of veil of ignorance. I've always quite liked that
Yes.
idea. And I think
Yeah.
there's a scholar, Norman, somebody who wrote a book called Just Healthcare, who draws upon rules. I'll remember the name.
Yeah.
But he does ask some quite interesting and quite challenging questions about age and
Mhm.
equity, in terms of if someone has, the extent to which someone has had life
Mhm.
may actually mean
Yeah.
pretty much against what many of us say.
Yes.
That lead.
Yeah, especially with end of life care decisions.
Yeah.
Yeah, there was an economist, a health economist in the UK called Alan Williams, who had this idea of fair innings. I'm not too sure it kind of translates to a baseball, but in cricket, you would have an innings that you've done quite well. You've got nearly 100 runs. You've done quite well. And the idea would be that you've had a full life, not just your 3 school years and 10, because we're up into the 80s now, but you've had a full life, and actually maybe those resources could be better directed elsewhere. Yeah. Daniels, thank you. Norman Daniels, yeah. From Boston, isn't it? I think it's somewhere. Yeah, I think he's in the US, yeah.
So I do love the idea of the Fuladi School of Public Health.
Sorry. She's going to kill me for that.
Very accurate, really accurate. But just along the line of, where this discussion is going in terms of age. My background is aging and disability. I do have to jump in here for a moment. And just looking at the idea of equity and inequality, age, by the number makes very little sense. And that, yes, maybe you had the same number of years, but people age very differently.
Oh, sure.
And have very different roles. And so, a 65-year-old is not a 65-year-old, a 65-year-old. They're all, very, very different.
Mhm.
So the idea of having those kinds of age limits takes a lot of thought.
I hope it comes across that I'm not advocating any particular one, but I think it's then interesting. My issues, and I'll come on to explain this, is how the policymakers, that's a very broad term, make those decisions. How did they reason through the thinking to justify their decisions? And my point, I think, is that by and large, they haven't really engaged with these processes and particularly the implementation of them as well as they might. So that's kind of my, but thank you for that.
Yeah, just like a small addition to this. I think part of it also just kind of my observation of healthcare, public health, is there needs to be also a willingness to bake the cake or cakes. And so often that is the challenge that healthcare system has with policy, right? Like willingness to invest, spend money, like the money's there. It's just not being, it's not being spent on public health. It's not, so what is the willingness of folks in those positions to actually invest in the system as it needs to be invested in
And
adequately.
that's
Yeah.
a good point, because that directs our attention as researchers to those people making those decisions. So trying to understand what they're thinking. Yeah, nice.
And just to piggyback off of Portia's comments, going back to the cake analogy, suppose if cake isn't for certain people, you know,
Yeah.
if it's celebratory, right?
Yes.
Suppose if you have someone
Good
who
point.
doesn't eat cake
Yes.
and would love to celebrate. So I think we also have to think outside of the box when we're thinking
Yeah.
about healthcare and the future and how is that going to work for everyone?
Yes, that's a good point. And Deborah Stone uses this analogy. Cake may not be the right one. Yeah. Particularly as Portia was mentioning food insecurity, Elliot. Yeah, I'll take that.
By the way, that was
I'll have to rethink the analogy.
that was Dr. Silvat Latouche Howard. Who was. That's the last question.
Hi, Mark, I'm just reminded of what you said earlier about so what are we actually looking at? So if we're staying with the cake analogy, we're staying with cake, right, with healthcare and healthcare resources. So what about baking a bread loaf or baking something else that's not, in those 15% that you said, is about health, is about healthcare.
Yeah.
So we need to think about baking other things as well, probably to think of how it affects, the use and the slicing and dicing of the cake potentially and icing.
I think no, that's a nice point, and I accept that. I think you could almost expand this into more sort of a societal approach. How does society divide up the cake? Education and public health and housing and etc. So I don't want to kind of put too much on this cake, but I think it's got a bit of mileage of the way in which we think about the problem. Anyway, hopefully that's just kind of primed you to thinking in a slightly different way. What I want to do now is kind of just shift to the part 2 of this, which is a lot of we've had some definitions and we've had some evidence of inequalities, at least from the UK, but I would argue that many of those diagrams, I could change the words, change the dates, and it would look pretty similar. Yeah, I don't think that is kind of news to you. But what I want to do is I'm interested then is the so what question. So what do we do about it? And the British government asked a bank chief executive, and I kind of underline that because I think this is an interesting issue that it went outside of healthcare. And he was the chief executive of a big group called the NatWest Bank, a major bank that did get into financial trouble in the financial crash of the late 2000s. But he was asked to have a look at this as kind of from a public health point of view. How can we maximize our contributions to public health? And this quote, I think, has stayed with me. There's some great material, and you can look up on that. These slides will be available for you all later. And he said, there's so much written, often covering similar ground and setting out the well-known major determinants of health. So, the evidence is there. And then this is the but point that I think is really important. But rigorous implementation of identified solution has often been sadly lacking. So we kind of know what it is, but we haven't done it, which then to me begs the question, why? So from a health policy, public policy point of view, my antennae are twitching here. Why have they not done this? So that in a way is the sort of segue into this section. So let's get into this a little bit more. I'm going to use the one of the graphs in the top right there that you've already seen before, but I'm going to take the work of Hilary Graham, who's a medical sociologist, just recently retired from York University in the UK, and she said that the policymakers need to be a bit more nuanced in how they're approaching this. And identified 3 different ways in which policymakers have traditionally, implicitly defined their policies or how they've designed their policies. The first one is the disadvantage. So it's the most common policy view. It's some sort of moral narrative to it, moral agenda. Those who are the most affected, the poorest would be the one. So in that sense, it is focusing on one particular group, and you see I've circled number 1 there to highlight it's those who have not enjoyed the benefits that other people have. Now, that could be a legitimate policy goal. Quite often that has been probably the most common in the UK. Be interested to hear how you would interpret that. The second one, and this comes back to the tube analogy, the gap, mind the gap, is the health gap. And that is the gap between two different groups, or between different groups, let's say, not just two different groups. It's focusing on a segment of the population, quite often minority groups. But in doing so, it underestimates the pervasive issues that are affecting the whole of the population. So in my diagram, I've just sort of highlighted, as it were, the two points. It's fairly random where they are, but the idea is there are two particular multiple different angles, but we're losing the systemic or the systematic effect across the whole of society. Remember, Barbara Starfield talked about this systematic effect. So perhaps it's not going to be the most effective kind of policy solution. And then the third one is called the gradient. And this is one that Michael Marmot would probably subscribe to. Because it's the systematic relationship right across society, from in my simple example here, from the most affluent to the most deprived. Okay, that's kind of a socioeconomic status measure, but we can apply others. It's about, why is that relationship such a gradient? And that was why I asked you earlier, what about the folks in the middle? They're doing okay, but why is it that? So it is not just trying to focus on a segment, it's looking at the whole of society, that we need to address those policies, but do it in a way that is much more systematic. And that sort of understanding has led into many countries, particularly, well, partly through groups like the European Union and the WHO, the initiatives called Health in All Policies. So it should not be allocated into a healthcare, please, not just healthcare, or even just health. It should be pervasive into a whole range of others, from transport, education, schools, everything. So how can you filter the kind of public health agenda across agencies that, on the face of it, don't have health as part of their agenda at all? There may be passing knowledge of the broader social determinants of health, and how would they get played out in an unequal way across society. So the challenge then is to get out into those agencies and start to engage with those. Now that's the problem. They're operating on a different model altogether. They're operating on different financial measures, different organizational culture, professional cultures. They don't have that sort of, they have maybe a very different approach to way of thinking about problems, of tackling problems. So it is not going to be easy at all to do that if we take the gradient model. Policymakers need to understand then that implicitly, or hopefully explicitly, they should be tackling one of these three approaches, or they will do. If you're going to tackle equity issues, you've got to address these. I pointed out some pros and cons. The gradient might be the most intellectually, as it were, coherent model or approach to approach it, but it's going to be the most intractable. It's the most difficult, because you're doing it the whole of society across the whole of those issues. I'm not saying the others are easy, but they will come with their strengths and weaknesses. So I found the work of Hilary Graham particularly helpful in trying to understand how policymakers themselves understand tackling equity. So I'm going to give you a little kind of case study now of how the National Health Service in the UK, particularly England, has been tackling it. But in doing so, I'm presenting a paradox here, because Very briefly, the NHS for short, centrally funded, open to all, free at the point of delivery. So in theory, we shouldn't have access issues. We shouldn't have financial barriers. It's pretty geographically available. You know, there are primary care doctors pretty much across the country. There's been a planned distribution of hospitals. Yes, they are tiered, so you'll have your big trauma centers and district hospitals, we would call them in the smaller towns. So on the face of it, equity tick. But Julian Tudor Hart, a primary care doctor in Wales 50 some years ago, identified the inverse care law. I guess you're probably kind of familiar with that, but anyway, the availability of good medical care tends to vary inversely with the need for it in the population served. And that's for a whole variety of reasons. Some staff don't want to go and work in particular areas. The facilities haven't been improved and upgraded in the way that others have. There's been a bias in the funding distribution that will reallocate resources in different ways. It's a whole myriad of factors. But even when he was writing, the NHS had been operating 20 some years, and we still have the inverse care law. So we are not by any stretch solved this conundrum. And although I'm plead guilty here, I'm focusing just on healthcare equity, but the issues still apply right across society. So let's just give you a few examples of how the inverse care law is creating a barrier for equity for the NHS. This graph shows the distribution of our primary care doctors by 100,000 by neighbourhood deprivation as we were identifying areas. So and it takes a period from 2015 to 2018. So perhaps in that period there hasn't been much change. There's been a bit of an increase around 2016, but the key point is the coloured lines here. So each of those is a quintile from the most deprived in the red, and you don't need to be an expert to know that's at the bottom of the graph. So they will have the least number of doctors, in this case per 100,000. FT is full-time equivalent, so it takes out those people working less than full-time. And as each quintile goes up, as you become progressively less deprived by neighbourhood, admittedly, there are more GPs, more primary care doctors. So if you're in the least deprived, the Q5, the blue line, you have more access to doctors. Now this data, okay, is just very recently. The NHS has been operating, well, actually it's 75 years this year in July. So this is a problem that has been in the making for 75 years. We still have a unequal distribution. Remember, this is the who and the what question, the access and inputs, in this case, staffing inputs by neighborhood. So on my matrix, I've got that cell ticked. So we've got a problem. We've still got a problem there. Hasn't gone away. Going back to one list, there's been a whole range of reports, evidence reviews. We know this problem, and I've just put a few up here. So we go back to 1980. There was what was called the Black Report, and in that case, it was Sir Douglas Black, who was the former chief medical officer. So an eminent, it would be like your Surgeon General. And then that was followed up by the Blue Report by the Atchison Inquiry, former chief medical officer. Again, 18 years later, we had another review. Then we had the two Marmot reports in 2010 and 2020. And again, they're saying pretty similar things. They have not, the evidence has changed. Obviously, the the source, the data, but the broad picture has not broadly changed. We still have those ingrained inequalities. So whether we go back to 1980 or down to 2020, there has been relatively limited policy development. The GPs are still distributed by area deprivation. Life expectancy has in some cases got worse. And I know we can argue that we've had, particularly in the last dozen years, we've had financial austerity and the cost of living crisis and COVID, and that has magnified that. But my interest then is, well, what have policymakers done about it? And that's where I've used in the past the model that's been called the multiple streams model. And this is taken from John Kingdon's work. Some of you might be familiar with. He was originally looking at US transportation, among other things. But the model is, I find it's quite nice and simple. It's an easy entry, but I think it's got a lot of depth to it, or can have it. And in this, the simple version of this is that change will only happen when three streams come together. If you think of a mountain stream, the small little mountain stream won't move the big boulder, but when three streams come together and the river's got a bit more power, then it will move the boulder. That assumes they will come together. This model suggests, well, maybe these streams don't always conjoin or align or integrate. So these three streams is the problem, the policy, and the politics. So the problem, in some ways, that goes back to Wanless, goes back to all those inquiries of evidence. We know the evidence. We know pretty much. Okay, we need to update it. We need to remeasure, have that continually approach, because otherwise we can direct our attention in the wrong direction. But it's the way in which the issue is framed, the way in which it's defined. So that comes down specifically to those, the who and the what questions of equity. But then we're getting outside of the traditional area of public health and health services research into the much more public policy area. This model comes from a kind of public policy tradition, really, political science tradition. And so the second stream is the policy stream, the competing strategies, the feasibility of them. And Kingdon talks about a primeval soup of all these different ideas bubbling around. It might be some think tanks, some non-profits and charities putting proposals forwards, payers, government, and out of this soup will get selected strategies that are feasible. They have to have some sort of at least face value feasibility, that they align with the dominant political values. So if you have a very right-wing government, don't expect strong redistribution, for example. And then the third stream is the political stream, the small p and the big P. I mentioned the big P in terms of maybe redistribution, but it's perhaps the smaller scale politics of bargaining and compromise between different stakeholder groups. I mentioned earlier about trying to engage with education or housing or transport. How do you get involved in that compromise and bargaining that gets them on side, but also allows them to achieve some of their objectives as well? How do you get that win-win? So these three streams might come together by chance. I wouldn't wait for it. I don't hold your breath. It could happen naturally. There may be a natural cycle. Elections, for example, quite often that natural cycle. There's a turnover of a new chief executive, a new charismatic community leader, etc. And that's where this idea of the policy entrepreneur becomes quite important. These are individuals who are use their resources, their social capital, their charisma, their power in the community, maybe their positional power as a chief executive, getting the issue on the agenda, to bring those three streams together. A bit like most financial products, investments can go up and can go down. Streams can align, but they can also separate. Some people use this instead of streams, talk about windows. Windows open, but they can also close. I suppose our model, we'd want to think about how we can wedge open the window or make sure the streams stay joined. Because while the problem is being continually redefined and remeasured, there are people who are shifting that framing away, that it's an individualized problem. It's an issue about your diet and your eating. It's your choice for health. It's not the system that's creating that. It's your decision, your personal decisions about when you visit the supermarket, about what you buy. And well, if it's a systemic problem, then we need to understand about how other people might reframe that and address that. So even just on the problem, it's not a simple tick done. Then we've got to address the other two. So I'm just putting a health warning out there that it's a streams join, but they can also separate. And it's for people like you, us, to make sure that those streams are continually joined or the windows are wedged open, at least sufficiently long enough to be able to make significant change. The danger is that they're open for a short time and the government minister moves on to another job, charismatic leader doesn't, retires, the financial position is not so positive. Times will change and that window of opportunity will be missed. I'm quickly going to go through the three as it applies to the UK and then I'll finish. So the problem stream in the UK, well, as I've mentioned, we've got a very large evidence base, increasingly around the world as well. But we're not short of data about the inequalities. There is increasing recognition of the social determinants of health and the role they play. But there is a danger that the social determinants are fused with the idea of equity, or maybe not fused rather. In other words, the policymakers will give themselves a tick because they're talking about the social determinants. The social determinants are not health equity. They are closely related, but they need to be integrated. Generally, the structural explanations have been broadly accepted, but there are still people who are pushing forward the individualized agendas, whether that's food and drink, whether that's some government politicians. It is not, I wouldn't say that is fully accepted. And that's particularly come out in issues of obesity. And I was involved in a NICE committee, which is, sorry, not nice as in pleasant. It was the National Institute for Health and Care Excellence, which is our kind of regulatory body. And the issue was around obesity. And it was slightly unusual because normally they look at pharmaceutical interventions and devices and other things. And originally the committee was called Whole Systems Approaches to Tackle Obesity. And the government didn't quite like that. So we had to recall it Community Approaches. But it's just the way the issue was reframed, not as a systemic structural issue. It was more sort of not quite individualized, but individualized to a community level, maybe. So that debate about whose responsibility this is not a done deal. Added to the problem is we've had two particular factors since then. I've mentioned COVID already, and also the financial constraints of cutbacks. And arguably post-COVID, we're going to be still facing that. Just in a health service context, the funding settlements are not great looking forward. We're not going to be flush with money for the next few years. So not a great picture on the problem stream. On the policy stream, there have been a number of different shifting positions at government level centrally. And one of those has been very kind of vague policy called levelling up. The idea that we should raise the a whole range of aspects, but raise the life chances of people in different communities. At one level, that's kind of good rhetoric, but it has yet to be really put into any sort of systemic, comprehensive policy. It tends to be a little initiative here, short-lived. I don't think anyone's really expecting anything to come from that, but it's been a bit of a slogan for governments recently. And that involved the shelving of legislation. So our policy goes through a number of different stages. And the one proposing legislation is called the White Paper. I guess because it's written on white paper. But back in February, the government shelved the plans called the Health Disparities White Paper, just like that. So we're not expecting any major changes in the short term. And that creates an issue because governments, particularly in the kind of British context, have been very poor at long-term issues. You know, I put climate change in there, I put sustainability in there, I put, you can add to that list. I would add health inequalities is a long-term issue, and we've been tended to be on short-term cycles, funding cycles, government ministers cycle of whatever, 2 years, maybe if you're lucky. You're not going to achieve, you're not going to be able to wedge that window open long enough if you're only in post for 2 years. At a more local level, and I'm thinking kind of city, neighborhood level, the public health function, the staff in there have been moved from the NHS, so they were NHS staff for many years, into local government bodies. But with local government, they are responsible for housing, transport, education. Now, is this glass half full or half empty? On the one hand, those are many of the social determinants. So public health are in the offices, in the buildings where a lot of those decisions are being made. The glass half empty is, well, they don't yet quite have the resources and the levers of power to be able to make those sorts of impacts because they are, well, relatively new, relatively small scale. So kind of the jury's out a bit on that issue. There's been a couple of initiatives developed locally. One is called the Core 20+5, the 20% poorest populations, looking at 5 clinical areas. I think diabetes is one of them, for example. But again, we're looking at that 20% poorest is a classic example of the disadvantage that I said was a bit not particularly comprehensive. It's not a great way. For example, if you're in the 21st category, you might miss out on many of these. There are some positive signs. There's a bit more integration happening, but broadly, there's a bit of a disconnect between what the problem is, how it's been defined, and the policy stream. And then finally, the politics. Many of our political discourse is still kind of in a more neoliberal, market-based approach, and that has been particularly through the years, the 2010s, through austerity, which had not seen the broader or not factored in the longer term implications. A lot of the political stream would come under much more rhetorical statements about inequalities. As I've mentioned a bit, to give you one specific example, would be whether the government should introduce much more regulation or have voluntary approaches. So we've banned smoking in public places, so trains, pubs, you don't have smoking. On the one hand, you can say that's good, but at another level, the first few years was trying to get voluntary agreements about sugar and salt in food. That has changed a little bit. We've had a sugar tax introduced, but if you look at places like Denmark, they've revoked that. It's not your panacea. It's not going to solve everything. There's an interesting development that we've had, which is about some engagement from the commercial industrial for-profit sector. And it's interesting that Michael Marmot now, part of his institute at the University College London, is directly engaging with that in ways that we haven't seen before. So the commercial determinants of health is particularly challenging. And then kind of from a political point of view, we've had pretty poor bandwidth since 2016. During this time, obviously financial austerity, we've had Brexit, we've had COVID. So for at least the last 7 years, the ABC, austerity, Brexit, COVID, has been just kind of squeezing out any other initiatives really. And I would include health inequalities in that. So it hasn't got the airtime that it should do. And also we've had a bit of a political turmoil with, I have lost count of how many prime ministers we've had in that time. So it just hasn't had that exposure, that bandwidth, policy bandwidth, even though there is an element of support and agreement for that. So where do we, I don't know where we how we conclude all this really, what do we take out from it? So the inequalities have been widening. COVID has exacerbated that. Yes, we've had a growing evidence base, and that's good. Positive, and contributions from the public health community has been great. We've had some attempts to tackle this, whether it's central government, local government. But part of my argument here today is that clarity of policy is really central to this. If we don't have this well defined and purposeful, then we perhaps shouldn't be surprised that this hasn't taken us forward. And we've got a paper that I've got with a professor of public health from Newcastle called David Hunter. It's not yet published yet, so here's our summary. There are some indications in each of the 3 streams that I presented, but it's not clear that they've been joined sufficiently to give confidence and ensure that the policy can be implemented and halt a state of worsening inequality. So I'm afraid it's not a very positive picture from the UK. Thank you.
Thank you so much.
So I'd be delighted to hear what you make of that analysis, whether that makes any resonance with what you experience in whatever capacity you involved in this.
Well, I'm just really glad. And when I first saw Mark's slides, I was really glad he brought in the idea of the 3 streams theory, the Kingdon 3 streams. We talk about this in policy courses. I mean, in our policy courses, we talk about this. And I wanted to kind of bring an analogy, or I guess ask the audience here. In our country, in the United States, we've had many times that we can look at the 3 streams theory and say it aligned and it didn't align, or it didn't align to elicit a change in this country. The best example I like to bring up is when the streams align, happen, right? Can any of you think of, and again, we're talking about healthcare. Can any of you think of when in the past decade or two, when it comes to healthcare, streams align? I know it. I want to see if you all learned it. Yes.
I actually took the policy class this past semester as a core requirement of my PhD program. And the big example we covered was the ACA in 2010. That was a big time when they all.
Affordable Care Act in 2010. There were many attempts to improve healthcare in this country, the United States, over many decades. The reason why the Affordable Care Act, and this is a good reason why the Affordable Care Act went into place, and the goal of the some equality within the system, right? That it was our attempt at universal care, which is not truly universal care, but it was our attempt to reduce the number of uninsured in this country between 2010 and 36 million. The numbers are higher. $3 million. But it was our attempt to reduce the number of uninsured and do some equity within the system. Now, I'm going to ask the question. We talk about the stream. Want to go back to the so people see the slide? The 3 streams: the problem, policy, and politics. At that point, 10, when the Affordable Care Act passed, why do you all think it passed? What were the conditions of the problems, policy, and politics that allowed it to pass? Can any of you think about happening?
But in what way was that also, just to add another question, in what way did that have an equity lens?
Yes. Yeah.
So that's a legitimate question.
Yeah.
In way, was there an equity lens? Yes or no, I suppose. And if so, how was it defined?
Exactly.
Maybe in terms of the who and what. There are
Yeah,
different ways of
exactly,
doing it.
exactly. So what do you all think? What was the problem at that time? So legislation passed 10, but it took time to come up. Right? What was happening in that time? Let's say in 2008, what was happening in the United States? Yes, Lola.
Okay, I don't know if this is correct, but I think there was a recession in 2007, maybe 8. So, so if a lot of people were out of jobs, and that means that a lot of people were out of jobs, then that means that they didn't have health insurance.
Which, as an observer from outside the US right now, it's just interesting why healthcare does not seem to be figured at all in many of your debate. I think it would be hard to find any discussion about healthcare reform in newspapers, in the media. I'm sure there is. And I guess the economy is, well, who said it's the economy stupid, but it's interesting in the UK, where that is less of an issue because we're not employer based. We still have had that slippage, and I gave some reasons why that might be, but yeah, sorry.
It tied in most people in the United States, I think. I don't know at this point. I mean, the distribution get their health care from their employer.
Right.
And so if you're unemployed, it ties in with a lack of health insurance.
Mhm.
And so that's into the perfect taking the economic problem into the problem is the lack of health insurance. We can't fix the economy right now. So why don't we at least give people health insurance so that that covers that part of it? Because then it turns into this loop of people are unemployed, they don't have health insurance, their health suffers, then they can't have health insurance, health suffer. It goes in this loop. From a policy and politics standpoint, you need a healthy, you need people to be engaged in the economy.
Yeah, there's a very nice talk by one of the officials from the Bank of England, bizarrely, you would think, whose argument is health is wealth, and he said we just have not figured it. The health agenda knows this, but the wealth, the economy driven aspects, the decisions made in that have not been connected. So well, I can share it with you. It's online.
Yeah, no, absolutely. So it was multiple factors. Let's see. Introduce yourself first.
Okay, so my name is Busola. I'm one of your students as well.
Sorry, folks.
Okay, so and I'm also taking a health economics class this semester. And so I'm going to answer the question that I know the answer to. So picking the problem as not being the broader ACA, but for me, I've been working all day on my paper on maternal health. So if the problem is maternal health and the policy is extending postpartum care to 12 months as opposed to 60, very specific example. But what's intriguing to me is the politics aspect of it. So when you mention things like bargaining and compromise, what is the politics? And we talked about the cake and the need for the cake. So right now, so with COVID-19 is the reason why why we're even considering extending it to 12 months. So what was the driving factors behind that? COVID-19 pandemic, was already a hindrance on people being able to work and their health. So what do? We would provide more insurance so that, just like she was explaining, the loop doesn't continue, and things like that. So all of those things had to align. Unfortunately, it was COVID-19 that also had to, play with the politics, that allowed us to compromise and bargain. But that's one of the things that had to align. So the problem, the policy, the politics of the COVID-19 allowed for the policy to pass to solve the problem.
Mm-hmm. So that's interesting because while you were talking, it just put it in my mind. Your original Head Start program here was lifted. I don't know if Tony here was policy transfer to the UK under a Sure Start program, and that lasted for a few years. So not just maternal health, but child health, early years health, up to the age of 5, which is when children go to school for the first time.
So
Mm,
both
mm,
of these
mm.
examples, that is, the answer to your question would be yes.
Yeah, right.
There is an equity lens,
Yes.
and how is it defined for
Yeah.
children or for?
Exactly. So you're targeting one particular group, and they would tend to be programs that would target those particular groups geographically, socially, in different communities. The challenge of that is that it lasted for a 5-7 years program, and then it got cut. So I'm not saying it was a bad initiative, but it probably needed more time to start to deliver some of those outcomes. There were some positive outcomes, but the challenge with this is it's kind of a generational change. I mentioned earlier about the long-term perspective that's needed. This wedging the window or the streams, joining them has got to be done for a long time. The generational change here is massive. So if you are going to affect the health of the children being born to mothers, you need to then think, well, when they become parents themselves, that's hard for government. We don't think in those time scales. Maybe one election period, or maybe two if you're lucky.
Exactly.
25? Forget it.
Yeah. And this is the challenge, when what I call that window of opportunity, when you have those streams aligning, right? And again, going back to Affordable Care Act, we had an economic recession. We had people losing their jobs. The challenge at that point for the population was either they were losing their jobs, but at the same time, they were losing their homes. They were going to the doctor. They were getting all these doctor bills, thousands of dollars. They were going bankrupt. So this was a huge issue in the population when it came to economic sustainability. And then we had the policy stream, which actually started many years ago. When we talk about competing strategies and actually things in place, at that point, around 2010, before that, we were actually looking at policies to improve health. We actually drew pretty much, I don't want to say rewrote, but we used the Massachusetts health reform policy of 2006, which passed. By the way, it was a Republican governor. So when we talk about the influence of politics, and it has a lot to do with political will, the state of Massachusetts in this country, although Republican Governor Romney, they are very liberal when it comes to social goods and thinking about their people, and very liberal approach to various public policy in general. So they had the political at that state in 2006. They passed the health reform. And we used that as an example. And when we put together the Affordable Care Act, it very much the Massachusetts universal approach to care. So we had these policies being written. We had groups working on that. So that was a stream. Then we had the problem. Okay, now we need to do something about it. And we had the politics. What was happening at that point? We were coming up to an election year, right? Obama. I mean, this was a huge thing. So all these streams aligned. There were things happening in society. We had a social, political, economic challenges all kind of work together, and we had a solution sitting there. And that's the reason why. If any of those streams were not aligned, it would not have passed. We had been attempting to do this in previous administrations, starting from the Clinton administration all the way up to
So
then.
one of the challenges is that those objectives may be very worthy, and that's good. But in doing so, that they could worsen health inequalities. So,
absolutely, yeah.
So particularly the emphasis in health improvement has been quite big in the UK, but you can improve health of some groups more
than others.
The
Yes.
danger is that particularly if you're using kind of much more kind of behavioral strategies, it might respond in particular groups. I think of smoking cessation, particularly that was a classic example in the UK. It widened inequality. So the objective was let's tackle smoking rates.
Yeah.
Okay, it's still about 15%, I think, in the UK. But the number of women, pregnant women who are still smoking pregnancy is still really high. The government had missed that kind of opportunity to have that equity lens built in, sort of baked into the cake.
Right. And again, I made that example to bring it back to that point.
Yeah.
You must have an equity lens when you pass, when you're trying to put with the ACA. But at that point, it was such a time, everybody was just trying to get everything done. They probably thought they had an equity lens, but they hadn't really dived deep enough into those factors, social determinants, all these things to try to bring it, keep them within the larger legislation. Somebody over there, Kate, you had your hand up.
Yeah, thanks very much. And I suppose it's that idea of where the evidence comes from, because the evidence often comes from Cochrane reviews and kind of that higher level of where it comes from. And the equity lens hasn't been in reviews. So that Cochrane is only bringing the equity framework in. It has just been, so when I look at the evidence, say for smoking cessation or anything, then what I say is actually, who were those randomized controlled studies? Who was randomized into them? Do they represent the people with the problems that actually is informing the policymakers and then the politicians, that kind of, so when you go back to that, it's that problem, who's defining it, where's the evidence? And that, I mean, it is quite interesting now, that equity frame.
That's a really good point, Kate. And actually, somebody else it goes back to who's funding the studies and making sure that equity gets into those funding
conversations. Yeah, no,
exactly. To deliver projects that deliver the papers that are going to get reviewed in evidence.
That's exactly
yeah.
it. It's like cyclical. So if you keep producing the same, you will end up with the same, that kind of, and like smoking cessation is a good one. How many more studies do you need? But the evidence didn't change the policy for banning smoking in public places. It actually then came from, it wasn't people dying of lung cancer necessarily, all that evidence that was stacked up. It was actually when, the Framework Convention on Tobacco Control, and then Ireland, they said in 2003, Ireland then was the first country then to bring that change in. But the legislative change came from the impact from health and safety on bar workers, people working in bars and restaurants. And it was health and safety legislation that made that initial change. Yeah.
4 years later, I think.
Yeah, that's it. Yeah. And no, but that's because they used that then, and all the other countries came in line. But all your evidence of the association with lung cancers or anything else, they're saying, is it not strong? Could it be something else, even though you'd have those long cohort studies?
This, and they use the example of smoking.
Yeah.
I think the American Medical Association and the Royal College of Physicians in the UK, I think in 1962 and 64, if I remember.
The Dolan Hill study, that was it. Yeah, that was it.
Leading up to 2007.
I know.
It took a long time to get that window or those streams aligned. But that's the generational, multi-generational in that case, initiative. I know that's not the end of the story. It's there's a whole lot of other policy initiatives.
This has been great. I just think it's.
In other words, it's taken, do the maths, 60 some years to get that to that stage, let alone other stages. I mean, we now have point of sale restrictions. You go into a shop in the UK, you can't just point to the tobacco. It's got to be behind a sliding door or under the counter, for example.
Oh yeah, but I look at, I mean, this is really interesting because I really like the policy makers, like Tudor, the all the laws from the 70s and all those perspectives you're getting on the inverse care law and everything that's still there, and nothing changes. So when I look at the point of sale would be one, and then I was kind of going, so you can't see cigarettes, but we still sell cigarettes. So it's not about actually hiding them. It's about saying, why do governments sell them? Why do they allow them to be sold? Because they make taxes. So why they make taxes is we need to have a conversation with what the retailers could sell instead. And then they say, oh, well, then it will be illegally traded, that kind of the black market. So I'm back in the countries that are growing tobacco, and I'm saying, what do we need to do for those communities to say how you can have an income that instead of growing tobacco plants, you can grow something else, because you're not making the money out of it. It's the tobacco companies who they give you pittance for, and that's what keeps you going. But that whole trail, but we'd say it's California is the only state where in certain areas that there's no tobacco sold, in that particular area, but it's highly unique. Do you know that kind of?
Worth looking at, because they're banning younger ages. So there's a whole cohort going through that won't be able to buy. They'll still be on sale, yeah. But to use that, a great example there, thank you, Kate, is how do you organize the policy and the politics to tackle that when you're talking about going to the countries growing tobacco or to the suppliers of that? Yeah, but that is a huge agenda. You know, you think kind of tackling it in one small community or one small neighborhood, that's hard. What you're saying is just
At that
kind
level,
of on a massive scale. That is huge. To be long enough to be able to wedge these streams. It is. And there is, I've just forgotten that name, but there's the kind of policy window that shifts and stays, isn't it? It's about how we normalize to a new way of thinking. So tobacco is much less acceptable now as it's still in some communities, but it's much less, you don't see it in the movies, and it changes the frame of reference for us. Yeah.
I would actually like, just going back to the ACA, but Affordable Care Act, hopefully to remember from their studying, it was not a standalone policy. It was tagged on to an omnibus budget policy. So again, we talk about we want to have equity lens, we have this intention, but it truly is not there, because if you have to tag a policy like this onto a budget legislation to pass, there's a problem. You see, so
yeah,
again, it's like a cycle, like you'd say.
and arguably you could say in the UK we've got a very generally a favorable climate, not entirely, but we've got a public health system that is public health system that is free and open. We've got kind of a solidarity principle that you often find across other European countries, and yet the government shelved their white paper proposing legislation. They just shelved it, and it hardly got a mention.
Well, that's because there were other things, like you say, happening that took precedence with your new prime. I don't know, like you say, I don't know, was it the third iteration in the past year?
Yeah.
How many prime ministers you've gone through? 2 or 3, and then for us, the reason why it doesn't come up in usual discourse until it's an election year, usually the presidential elections, and that becomes a hot topic. So it's always on the back burner until, again, you have a major problem stream happening, then all the talk comes up, right, at every single election. But again, there are certain political situations that take precedence.
Focusing the discussion quite rightly at kind of national level. But this model can also apply at the community level, city level. So yes, you've got a mayor who's got a strong agenda on this. You've got a director of public health who's got you might have some sort of other community leader. So, I think there is change, but you're not going to see the change big enough to change some of those graphs that I was saying earlier. It might do in your neighborhood, but across the country, across a bigger canvas, bigger picture, it's not going to change the dial that much.
Or change is happening again with like mass. That happened. They had a political will, and there's also other local things happening at the. But again, taking it from downstream upstream is a huge challenge because of all those externalities, like you say, and individual behaviors. When it comes to making and ideals, and it just makes it very challenging.
Yeah, I think this is really good because you can also think about. I think about it as like the volume of this.
Right. Yeah.
Bandwidth pressure of all. You could have streams joining, and one of them.
Yes.
Have much come out. Looking from downstream, people using it to start. People start, people start drawing from the stream because they need to, survive and subsist on whatever it is. So, people looking from the top down can say, well, people are using the water. It looks like it's working. Not that big of an issue. People are managing with the water. And it takes a lot of time and pressure and momentum to push all upstream and really force.
And remembering that there's a lot of forces pushing the water back upstream.
Oh,
in various ways, whether it's a resistance of some political groups, or whether it's I don't know, aspects of the food and drink industry resisting some sort of regulation on their products, etc.
Yeah.
Yeah.
So it's a lot of forces going back and forth,
Yeah,
and
yeah.
in order to push it in the right direction. And also, yeah, like what using, I think a lot of, especially on a large scale, when you look at national policy or even, local county policies,
Mhm.
there's a lot of back on individuals, back on groups,
Yeah.
back on private sector of
Yeah.
like being able to manage, because you compare something like healthcare to any other industry, and the other industries seem to be sort of self-sufficient or self-cycling, and they regulate themselves. And so all the solutions that we apply to other industries, we try to apply to health. So like, I think one big thing with the ACA that came up is this huge influx of data. We have so much about and healthcare measures, and the amount of data collected is tremendous. And the idea was, okay, so the problem was we didn't have enough information. So here's all this information. Shouldn't it be obvious? We
Yeah.
gave you all the information. Shouldn't it be obvious what to do next? And the reality is it's not obvious what to do next, and it's not a given.
Yeah, and that was the kind of the oneness quote. We've got the data, we know a lot. But what we've lacked is the solutions and the implementation of that solution. So he was writing 20 years ago, but I think that still is relevant today, sadly.
I think we should have another talk sometime down the line about that. That starts going into evidence-informed policymaking, evidence-based policymaking, and how you present information to policymakers to help them make these decisions.
And I think
whole class in itself, folks.
I think that's particularly relevant for School of Public Health, because it's not that you do, of course, it's other people, but it's about don't stay in your community. What's that phrase? Stay in your lane. Well, don't stay in your lane. You've got to get out and talk to a whole range of other folks that are not public health.
Yeah.
Particularly not public health. You've got to engage with this. So it's a big challenge, and in a way it's about teachers of public health as well, making sure that they're connecting with schools of public health, schools of government, business schools, other groups, at an educational level, let alone getting that. So try and reach out all the time.
Yeah.
One aspect just.
Tilo, call from. I'm just introducing you.
And thanks. I just one thing I think that's highly probably also underappreciated are the non-rational factors, so because I think a lot of things when we think about evidence-based decision making assumes that the rational forces at play, that selectively picks out that, but I think what's really happening is political agendas, emotions, this back and forth is something about who will win the argument. It's not so much about what's right anymore. So I think there's a whole sort of field that's probably relatively untapped about sort of how people actually make decisions that are not based on rational factors, but are there non-rational influences, Yeah.
But particularly in policy terms, it addresses what we would call poor, somebody who is, let's say, smoking, not eating the right food, they're under, and so there's a whole lot of moral. Yeah, thank you, Tilo, because I think that is important. There's a whole lot of moral templates that are put onto people that shape the way in which we respond as a society. Absolutely, yeah. And we see that, with migrants in your southern border on our English. We see that with people who are financially poor in the UK, and how they in work but financially poor still, how they can make their kind of healthy decisions. A whole range of that moral agenda, which and non-rational. Well, I think that's good.
Okay. Let me quickly ask, do we have any questions from our virtual audience at this point? Okay. Well, in in keeping with the time, we are over. I'm going to wrap up this session. I want to thank you, Professor Axworthy, very much. Yeah. Thank you very much for this wonderful presentation and something that is universally a problem across every single country around this world. It doesn't matter where you go. Equity
Yeah.
is an issue. And it becomes more of an issue. And we need to find strategies to globally address it across nations. Yes.
I think I did mention, but the slides will be available
Yes.
from Nadine, so we'll find a way
Yes.
to get them out to you.
We will distribute the slides to our virtual participants as well as in person. If you all have any questions about this, please reach out to us.
Yeah.
And I will
Yeah,
pass
feel
around the
free,
contact
please do.
information of all the speakers we've had in the symposium. I want to thank all of you for coming. Many of you have come for each session every day, and I want to thank you for that, and as well as virtually. Again, this was our very first symposium. We plan on doing these more often every year if we can. We're in the talks of that. And Mark, you want to tell them a little bit?
On that specific point, if you've got ideas about what we could do, we're just a vehicle for it, really.
Yeah.
But, if you want to jump on board that vehicle or got suggestions for what we should do, please put them forward. We are an open page.
Absolutely. Reach out to us. We would love to put together some projects if you're interested, maybe some opportunities for you to work on these types of issues, anything you've heard in the past 3 days. So we're here as a network to help connect you with each other and others that are in that particular focus area that you're interested in. This is our goal. So please reach out. Again, thank you very much. I will wrap up and have a wonderful evening. Thank you all.
Thank you.
Thank you so much.
All right.